Welcome to The Explainer. Hey, if you're a medical trainee, you're going to want to pay close attention to this one. Today, we are breaking down the clinical management of schistosomiasis, walking you through everything you need to know from the moment a patient presents all the way to a cure.
Okay, let's dive right in. Now, before you even think about treatment, you have to ask yourself one fundamental question. Where did my patient get exposed? Because it all boils down to these two completely different goals. See, in an endemic area, where your patient could get reinfected tomorrow, the goal is pragmatic. You just want to reduce the worm burden and prevent long-term damage. But for a traveler, someone outside that setting, the goal is absolute. You are aiming for a definitive cure. Getting this right from the get-go changes everything.
So, here's our roadmap for this explainer. We're going to start with the big picture, then walk through acute and chronic infections, tackle the really scary complications, and finally we'll close the loop with follow-up and prevention.
All right, let's kick things off with the core principles, the foundational ideas that are going to guide every single decision you make.
So the main weapon in our arsenal is this drug, praziquantel. It's fantastic at what it does, which is paralyzing and killing adult worms. But, and this is a huge but, it does absolutely nothing to the immature worms or the eggs. And trust me, that's not just a minor detail. That one fact dictates the timing of your entire treatment strategy, as we're about to see. Okay, so let's jump into the acute phase. This is where things get interesting, because how a patient shows up is going to tell you exactly what you need to do right away. So when a patient comes in with an acute infection, you're usually looking at two totally different scenarios. On one hand, you've got cercarial dermatitis, what people call swimmer's itch. It's just a localized rash. Your job here, simply manage the symptoms, that's it. The parasite isn't mature, so your big gun drugs won't work anyway. But on the other hand, you have catamia fever. This is a full-blown systemic inflammatory illness, and it is a completely different ballgame that requires urgent action. So you've made the diagnosis. The patient is sick, they're febrile, they've got catamia fever. What's your very first move? This is a really key decision point. The answer, and this is a massive clinical pearl, is that you have to suppress the inflammation before you even think about killing the parasite. Why? Well, think about it. If you go in and kill all those worms right away, they release a massive flood of antigens. That could push a really sick patient right over the edge. So your absolute first priority is to calm that fire down with steroids. And this timeline is the game plan, laid out perfectly. So right away, you're hitting them with glucocorticoids. Then, and this is key, you wait. You have to wait at least 8 weeks after they were exposed for those worms to grow up so the praziquantel will actually work. Then you give that first dose of praziquantel, but you give it with a little steroid chaser to prevent a flare-up. And finally, about 6 to 12 weeks after that, you give a second dose, no steroids this time, to mop up any straggler. Okay, now let's shift gears to what you'll probably see more often, managing a patient with chronic, established schistosomiasis. So here's the good news when it comes to the chronic phase. Our go-to treatment works really, really well. I mean, look at this. For certain species, a single dose of praziquantel has a cure rate of nearly 95%. That's huge. That number should give you a ton of confidence right off the bat. I love this table because it just makes your decision process super clear. Let's walk through it. For a patient who lives in an endemic area, you give one dose and you're done. Reinfection is just too likely to chase a cure. Same for a traveler. If you don't find any eggs, one dose is probably enough. But look at that last row. For a traveler where you do find eggs, remember, the goal is a definitive cure. So you treat, you schedule a follow-up exam in 12 weeks, and you're ready to repeat the dose if it's still positive. All right, now we need to talk about the really serious stuff. Most cases are pretty straightforward, but you have to be ready for those moments when the schistosoma eggs go rogue, and the stakes get much, much higher. So these eggs can cause some really devastating damage when they end up in the wrong place. We're talking 3 major systems here. They can lodge in the liver and spleen, causing portal hypertension. They can mess up the urogenital tract, leading to renal failure. And the one you really, really have to worry about is when they get to the central nervous system, causing seizures or spinal cord problems. That's neuroschistosomiasis. If you remember only one thing from this entire explainer, please let it be this. Just like with catamia fever, but with infinitely higher stakes, giving praziquantel first here is a catastrophic mistake. The inflammation it would spark in the brain or spinal cord could cause damage that you can never undo. I'll say it again. Steroids must come first. No exception. So the management plan here is non-negotiable. It's a clear three-step process. Step 1, you start high-dose steroids to get that inflammation under control. Step 2, and this is important, a few days later, once the steroids are on board, you can safely give the praziquantel. And step 3, you keep them on steroids for at least a month with a slow taper, because those eggs can cause trouble for a long, long time.
Okay, we're on the home stretch. Let's talk about closing the loop. How do you confirm the cure, and how do you counsel patients so this doesn't happen to them again? So here's a question that trips a lot of people up. You've given the treatment, but how do you actually know the worms are gone? Choosing the right test of cure is critical. Otherwise, you can get really misleading results.
Honestly, the most important part of this slide is the don'ts column, because this is a super common pitfall. Antibody tests, PCR, these things are going to stay positive for months, sometimes years, after a successful cure. They tell you about exposure, not an active infection. So for follow-up, you need to look for direct evidence, either seeing the eggs under a microscope or detecting a parasite antigen. Ordering serology to confirm a cure is a classic, avoidable mistake.
So what do you tell your patients who travel? Well, the advice is actually pretty simple. The number one most important thing is that first bullet point. Just stay out of the fresh water, period. No swimming, no wading, none of it. And if they do have an accidental exposure, they need to know to come see you for testing about 12 weeks later. You need to give the infection time to actually show up on tests.
So I want to leave you with this one last question to chew on. For a long time, we've thought of this as a disease of other places. But as the climate changes, as the snails that carry it move into new territories, and as global travel gets back to normal, is this something you need to be more prepared to see in your own clinic? It's a question worth considering.